into the rotatory cuff anatomy. Rotatory cuff usually contains four muscles. One is the subscapularis. This is the supraspinatus. This is the infraspinatus and the teres minor. These are the four muscles which constitutes the rotatory cuff. So if we see the anatomy of rotatory cuff, this is the axial image, what we are seeing here. So if I'm scrolling through this red one, what we are seeing anteriorly, this is the anterior part. So this is the coracoid process. This is the anterior. This is the posterior. This red one is the subscapularis muscle. This is the footprint or tendon of the subscapularis. Then we have this blue one is the infraspinatus muscle posteriorly. If we go up, we have the supraspinatus. So I'm going from above to down. So this is the clavicle. This is the coracoid acromion process. As we go down below the acromion, we see the supraspinatus muscle. As we go still further down, we see the infraspinatus. Then further down, this brown color thing is the teres minor muscle. Okay. This anterior thing is the subscapularis muscle. These are the four muscles of the rotatory cuff. This is a sagittal image showing the rotatory cuff muscles. This is the anterior. This is the posterior. Anteriorly, here we see the subscapularis. This is the supraspinatus, infraspinatus, and teres minor. As we all know, the subscapularis muscle goes and attaches. As I'm tracking it, it will go and attach onto the lesser tuberosity of the humerus, and the supraspinatus, infraspinatus, and teres minor attaches onto the greater tuberosity. So this is the anatomy of rotatory cuff. So once we see the anatomy, then we are going into the tears. What are the different types of tears? Whether it is a full thickness tear or a partial thickness tear. If we are talking about a full thickness tear, that doesn't really mean that full thickness tear is a complete tear. If we see here, this is a full thickness tear, but the anterior fibers and posterior fibers are spared. The entire thickness of the tendon is torn, but not the full width. So this is a incomplete full thickness tear. Here also is another example where we can see incomplete full thickness tear. Here we see the partial width thickness tear of the anterior fibers, where the tear is involving the entire thickness. Here comes the posterior full thickness tear with partial width. So not necessarily the full thickness tear should be a complete tear. Here we can see a complete tear where complete width and complete thickness of the tendon is torn. So in a coronal we see this is a complete tear. Then comes the partial thickness tear. What are the different types of partial thickness tears? Usually we describe them whether it is a bursal surface, whether it is a supraspinatus tendon if you see. So this is the bursal surface of the supraspinatus and there is a partial thickness tear. Similar tear, if it of partial thickness, if it is seen on the articular surface, is an articular surface tear. And if it is in between, that is an interstitial tear. One more tear is there, that is a massive tear. We say a tear is a massive tear when the full thickness tear involves multiple tendons of the rotatory cuff. That is a massive tear. This is the basic classification of rotatory cuff tears. If we see the footprint, this is a supraspinatus footprint. Footprint tears can be of these four types. One is a pasta lesion, which is a partial articular supraspinatus tendon avulsion. So only the articular surface fibers got avulsed. Or it is a reverse pasta, which is opposite to the pasta lesion. Or a full thickness tear, where there is complete tear of the footprint. And other thing is a concealed interstitial delamination tear, which is an interstitial tear located within the footprint. So this is a concealed interstitial delamination tear. These are the different types of footprint tears. What exactly we have to see in a partial thickness tear? We have to see, as we discussed, whether it is an articular surface or a bursal surface, or it is an interstitial tear. What is the type of tear? Then if it comes to the articular side, Then whether it is a pasta lesion, which is a partial articular surface tear, or a rim rent tear involving the footprint. Based on the depth, it is like if the tear is less than 3 mm, then it is a grade 1 tear. If it is 3 to 6 mm, then it is a grade 2 tear. If it is more than 6 mm, that is a grade 3 tear. I will now show some cases of partial thickness tear. So one thing I will start with is a rim rent tear. So this is a coronal image, sagittal image showing a small tear at the footprint where all the fibers are intact except in the interstitial part at the attachment of the footprint there is a small tear. This is a rim rent tear. I can show the similar thing on coronal image. Here we can see this is a rim rent tear. Our articular surface fibers are preserved, or basal surface fibers are preserved, but there is a small tear here. This tear is called rim rent tear. This is our supraspinatus tendon. So this is one of the partial thickness tears. Then comes an interstitial tear. This is a sagittal image showing interstitial tear. This bright signal, what we are seeing on this PD weighted image, is a interstitial tear. On coronal image, we can see the similar thing. This is the interstitial tear with preserved basal surface fibers and articular surface fibers. I want to show one more type of tear, which is called concealed interstitial delamination tear. So we can see a bright signal within the footprint. This is a concealed interstitial delamination tear. Corresponding sagittal image showing a bright signal here with other fibers being intact. This is a concealed interstitial delamination tear. One more partial thickness tear. This is a partial articular surface tear or a pasta lesion. We can see a tear located in the anterior fibers of the supraspinatus at the footprint involving the articular surface. This is a pasta or partial articular surface tear. As we spoke previously, there is one more thing called reverse pasta. So that reverse pasta lesion where we can see a few articular surface fibers are intact. These basal surface fibers are gone. The footprint is completely gone. This is a reverse pasta lesion or a near complete footprint tear. So this is one more case. So these are the few partial thickness tears which I wanted to show. Then comes the full thickness tear. So if we go into the full thickness tear, as we discussed, it can be a full thickness incomplete tear or a complete tear based on size, whether it's a small, medium, large, or a massive tear. Then whether there is any atrophy of the muscle secondary to this full thickness tear that needs to be mentioned, and the location of the tear, the tendon in which the tear is there, whether it's supraspinatus, infraspinatus, or teres minor or subscapularis, and extension, both width and thickness of the tear needs to be mentioned, and the shape of the tear. Usually with the full thickness tear, there will be fatty atrophy or fatty degeneration. This is given by Gautelier classification as grade 1, 2, 3, and 4, where grade 1 contains only some fatty streaks. Grade 2 is fat is there, but it is less than muscle. Fat equals to muscle is a grade 3, and fat, if it is more than the muscle fibers, then that is a grade 4. Based on the tendon retractions we have, so Patty's classification, where this is a stage 1 retraction, stage 2 retraction, and a stage 3 retraction. Our point is the mid-humeral level. If it is if it is not reaching the mid-humeral level and it's near to the insertion, then it is a grade 1. If it is still, if it is at the level of mid-humeral level, then it is a grade 2. And if it is beyond the mid-humeral level, near to the coracoid process, then it is a grade 3. This is retraction, which helps orthopedic surgeon to decide before the surgery. So this is the different full thickness tear. So if we see one such tear, this is an avulsion. This is an avulsion of greater tuberosity. We can see here. This is a greater tuberosity which is avulsed. The supraspinatus tendon is intact. It is edematous, but no fibers are torn. The bone is slightly displaced from the greater tuberosity. So this is an avulsion fracture of greater tuberosity. Other thing is a complete supraspinatus tear. This is a complete supraspinatus tear, but it is not at the level of footprint. It is in its mid substance. At the mid-humeral level, there is a tear. There is mild retraction of the proximal and distal fibers from the level of tear. This is a complete tear where almost all the full thickness and full width, as I am scrolling, are completely torn. Then comes the stage 1 retraction, as we discussed, full thickness tear with stage 1 retraction. So here we see the tendon is torn, but not reaching to the mid-humeral level. This is my mid-humeral level. The tendon is torn and retracted only till this level. Approximately only 11 mm of retraction is there. This is a stage 1 retraction. We have a stage 2 retraction of supraspinatus here, where the tendon will reach till the mid-humeral level. This is my mid-humeral level approximately. So my tendon is reaching the mid-humeral level. This is a stage 2 tear. Then the stage 3 retraction of supraspinatus. The tendon almost torn and retracted till the level of coracoid process. So here we see, this is the supraspinatus tendon, this is the supraspinatus muscle, this is the spinoscapula. So this tendon is retracted till this level. Our mid-humeral level is somewhere here. So the tendon is retracted this much. So it is a stage 3 retraction. Then let us see something called massive cuff tear, where more than one tendon is torn. Here we can see the supraspinatus is not visualized. Along with that, if I'm going and seeing in a sagittal plane, this is my supraspinatus, this is infraspinatus, and this is subscapularis. As I'm tracing it further towards the insertion, we see supraspinatus is gone, infraspinatus is gone, part of subscapularis is also gone. This is a massive cuff tear. So once we have cuff tear, as we discussed, there can be fatty replacement. There will be fatty replacement. So here we see one case of fatty replacement where the fat appears in these images as dark. This dark thing is entirely fat. This gray thing is a muscle. Okay. In the PD, that is a proton density weighted images, PDFS, fat SAT. So we are suppressing the fat. So suppressed fat appears as dark. So if you see, this is our rotatory cuff muscles are somewhere here. This is subscapularis, supraspinatus, infraspinatus. If we see, the supraspinatus is almost completely replaced by the fat. The subscapularis is almost completely replaced by fat. So it's almost grade 4 goutillier fatty replacement. So this is about fatty replacement and about the rotatory cuff tears. So as we discussed, rotatory cuff tears can be like full thickness or partial thickness. Full thickness tear usually can be incomplete or complete. So partial thickness tear can be bursal surface, articular surface, or interstitial. Or if it is at the footprint level, it can be concealed interstitial delamination tear or partial articular surface tear or reverse pasta lesion. So this is about the cuff tears. Now let's come to the ligaments and labrum of the shoulder. So if we see the sagittal section showing the labrum, this is the labrum, glenoid labrum. This is our bony glenoid. Then the biceps tendon. This coracoid process, which is seen, this is the anterior part. So this is the coracoacromial ligament. From the coracoid process to the clavicle, we have two ligaments, that is the conoid and trapezoid parts of the coracoclavicular ligaments. Then if you are coming to the shoulder ligament, shoulder joint proper, we have the superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament. Inferior glenohumeral ligament is a bigger band with two bands like anterior band and a posterior band. In between this is the axillary pouch. So superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament with a axillary pouch. One more ligament which is of importance is a ligament connecting the glenoid and the coracoid, that is a coracohumeral ligament, CHL or coracohumeral ligament. So with this background, once again we go into the anatomy. I will turn off the annotations. Yeah, here this is the pink one is the coraco. This is a sagittal image. If you see, this is a biceps tendon. Anteriorly and superiorly to this, we have a coracohumeral ligament. This is the coracohumeral ligament. I'm just telling you the labeling. At this point, we see this 1, 2, 3. This is the superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament. Usually, these ligaments are best depicted on arthrogram images than a plain MRI. So, with this anatomy, we then go into normal variants. What are the normal variants we see in a glenoid labrum? Normal glenoid labrum is circumferentially covering the bony glenoid like this. Sometimes, if you see this, this is from 11 o'clock to 1 o'clock position, there can be a small recess. So that is a sublabral recess. It's a normal variant. Then we can have something similar thing extending from 1 o'clock to 3 o'clock position. That is a sublabral foramina. And very rarely we see absence of bony glenoid labrum extending from 1 o'clock to 3 o'clock position. That is a Buford complex in which there is absent labrum along with thickening of the middle glenohumeral ligament. So these are the normal variants. So why we should know the normal variants is because we don't have a labral tear like a Bankart lesion, something coming up here. So usually what is the thing we are looking at this point is a superior labral anteroposterior tear or a slap tear. Slap tears happen to be in this location. So we should not confuse the tear with this normal variants. We see here, this is a normal thing. This is a sublabral recess. Like it is a recess, just a concave thing following the contour of the glenoid labrum. This is a sublabral recess. This is a sublabral foramina, extends through and through. Okay. And a soft, and then we come to the pathologist. This is a soft tissue Bankart, where there is loss of anterior-inferior glenoid labrum at this point. So this is the soft tissue Bankart. Then we have, then we have a Perthes lesion. So what exactly is a Perthes lesion? Is like it's a part of this soft tissue Bankart only. There will be detachment of the anterior-inferior labrum with, but this labro-ligamental complex will be intact. It will not be displaced medially somewhere here. So there is a soft tissue Bankart. There is some periosteal avulsion, but there is no displacement of this glenoid labrum from that point. So we have a GLAD, that is a glenoid labral articular disruption, where the Bankart lesion is extending into the articular cartilage. Or the other thing is ALPSA, which is anterior labral periosteal sleeve avulsion, where we have avulsion of the periosteal sleeve, and this labro-ligamental complex comes down and it will be there at the medial aspect of the glenoid. So another lesion is a reverse Bankart. Usually Bankart lesion happens anteroinferiorly. If it happens opposite to that, that is a reverse Bankart. It is a rare thing. Once having this knowledge of normal variants, labral anatomy, and what are the different types of Bankart lesions, then we move into on-track and off-track shoulder lesions. So what is an on-track and off-track shoulder lesion is like a glenoid, if we have a glenoid tract. So glenoid tract in a normal healthy individual or a living human being is 83% of the glenoid anteroposterior diameter. If we draw an anteroposterior line along the glenoid center point, then that if we divide it by 83% or 0.83, that is a glenoid tract. So what we are doing in a Bankart is this small d denotes the loss of bone. The loss of bone, if we subtract from the normal glenoid tract, we get the actual glenoid tract in a Bankart lesion. So then we need to know Hill-Sachs interval. Hill-Sachs interval, it is so, this on-track and off-track is a bit confusing, and it's an extensive topic. I'm not going into deep of it. Just I'm reading it for you. If you want, we can go into depth of it later on. So in Hill-Sachs interval, what exactly happened is like this Hill-Sachs interval is the Hill-Sachs defect plus the bone bridge which is there between the defect and the muscle attachment. Why we are looking at it is like if the Hill-Sachs interval is less than the glenoid tract, so then that is an on-track lesion. So an on-track lesion do well with the surgery. Yeah, or if it is like the Hill-Sachs interval is very large and it is more than the glenoid tract, so it is not going to fit the glenoid tract. So then it is like it will easily dislocate, and chances of recurrence are more with an off-track lesion. So with this knowledge, we will go and see some Bankart and Hill-Sachs lesions. Here, if you see what exactly is happening, these are axial images. This is the anterior aspect. This is the posterior aspect. I'm scrolling down. Then I'm seeing a fluid signal which is separating the anterior glenoid labrum from the bony glenoid. Here we see the posterior glenoid is nicely in the posterior labrum, which is nicely maintained and is attached to the bony glenoid. Here there is a tear. So this is an antero-inferior glenoid labral tear or a soft tissue Bankart. So Bankart is usually associated with the bony depression along the posterolateral aspect of the head of humerus, that is a Hill-Sachs lesion. Here we can see there is a defect. This is a normal contour. Here there is a depression, and because of the depression and injury, there is an edema underlying, bone marrow edema. So this is a Hill-Sachs lesion. This is a case of Hill-Sachs and a Bankart in a patient. I am going to show another case where it's a rare one. This is a reverse Bankart, as we spoke previously. So usually in the Bankart, we see antero-inferior labral tear, right? So if I'm scrolling here, we see here the posterior labrum, posterior-inferior and posterior labrum is detached from the bony glenoid. This part is the periosteal sleeve. There is some avulsion of the periosteal sleeve with the fluid extending into the tear. This is a reverse Bankart lesion as it is posteriorly placed. And associated with this, there is a reverse Hill-Sachs lesion sitting over here in the anteromedial aspect of the humerus. This is the humeral head. This is the anteromedial aspect. So we call this reverse Hill-Sachs lesion as McLaughlin lesion. So it's a rare one. So this is a case of reverse Bankart. So usually to see a Bankart lesion or a Hill-Sachs lesion, we have to see axial images. The axial images are better images to see a Bankart and Hill-Sachs lesion. Even a sagittal will show you, but that requires thinner sections to view. So this is about the labral Bankart and Hill-Sachs lesions. Then comes the other thing, as we spoke with the normal variants, where like sublabral recess, sublabral foramina. So in that location, from 11 o'clock to 1 o'clock position, we have flap tear. Flap tear is superior labrum, antero-posterior tear. Superior labrum, antero-posterior tear. So type 1 tear involves only labrum. Type 2 extends into the biceps anchor. This is the biceps anchor. The stalk is the biceps anchor. So which extends in the biceps anchor is a type 2 tear. Then comes the type 3 tear, which is a bucket handle tear. This is a bucket handle tear. If the same bucket handle tear extending into the biceps anchor, that is called a slap 4 tear. So these are the 4 types of slap tears. I am going to show you slap 2 tear. So slap 2 tear is a tear, superior labral antero-posterior tear with the tear extending onto the biceps anchor. So as I'm scrolling here, we can see this is the superior labral tear. This is the biceps anchor. This tear is extending into the biceps anchor. So superior labrum is taut and this tear is extending into the biceps anchor. This is a slap 2 tear. We can see the same thing even on coronal image, sagittal image. Here, see here, this is the fluid filled tear, which is bright. This is our biceps anchor. We can see this biceps anchor. The tear is extending into the biceps anchor. So this is slap 2 tear. Then these are about the slap tears. Once we are done with the slap tear, we go into something complex called rotator interval. So rotator interval, what exactly is rotator interval? Is the interval between the supraspinatus tendon and the subscapularis tendon. This place is a rotatory interval. What exactly are the landmarks of rotatory interval? Anteriorly, we have the coracohumeral ligament. Then superiorly, there is a supraspinatus tendon. Inferiorly, we have subscapularis tendon. Medially, we have coracoid process. This is the coracoid process which is seen medially. And laterally, we have transverse humeral ligament. So what is the content of the rotatory interval? Usually the long head of biceps courses through the rotator interval. So that is the importance of rotator interval. For understanding, this is a hand-drawn image of one of my friends. So we see this is the coracohumeral ligament. This coracohumeral ligament has 2 bands. One band which is laterally placed, that is called lateral coracohumeral ligament, lateral band of coracohumeral ligament, and medial one is a medial band of coracohumeral ligament. This medial band of coracohumeral ligament joins superior glenohumeral ligament. Okay, and these 2 things arches around the long bicipital groove, forming transverse humeral ligament. So this is the basic anatomy. Once I'm going to repeat the same thing again because it's a bit complex. This is the coracohumeral ligament. Coracohumeral ligament, which is the green one. This coracohumeral ligament has 2 bands: the lateral band of coracohumeral ligament, the medial band of coracohumeral ligament, and this medially, this medial coracohumeral ligament joins with superior glenohumeral ligament and stays here. So it will attach to the lesser tuberosity. This will attach to the greater tuberosity. In between fibers are the transverse humeral ligament. So what are all the things we are looking at in the rotator interval is biceps instability. One thing is biceps instability. Second thing is periarthritis shoulder. So we are going into the biceps instability. First thing is a normal axial image showing the humeral head, glenoid. This is the subscapularis tendon. This one is the coracoid process, and this is the long head of biceps tendon. As we discussed previously, as is shown in this image, see here, this is the lateral coracohumeral ligament attaching onto the greater tuberosity. This is the greater tuberosity, lesser tuberosity. This is the lateral band of coracohumeral ligament. Here comes the medial band of the coracohumeral ligament and superior glenohumeral ligament complex. And medial most thing is the subscapularis tendon. This is a Bennett's classification of biceps instability, in which we have type 1, type 2, type 3, type 4, type 5. So type 1 comes here where there is partial or full thickness tear of subscapularis tendon only. All other ligament complex is intact, because of which the long head of biceps tendon moves medially or subluxate medially within the bicipital groove. I am showing the same case here. Bennett's type 1. These are the axial images. Once we see here, this is the subscapularis tendon. This subscapularis tendon, superiorly, there is partial thickness tear. This is my bicipital groove. As we see, this transverse humeral ligament is intact. This part, as we discussed, is the lateral band of coracohumeral ligament and medial band of coracohumeral ligament. If you see, the long head of biceps tendon is subluxated medially because there is tear in the subscapularis, partial thickness tear in the subscapularis fibers. So this is Bennett's type 1 biceps instability. When I'm going back, so here we see medial subluxation of long head of biceps tendon. This is a type 2 where the biceps tendon, the subscapularis tendon is intact, but there is tear in the superior glenohumeral and medial band of coracohumeral ligament complex. So that is Bennett's type 2. Then we have a Bennett's type 3. In type 3, it's a combination now. It's a tear of this medial half of the middle band of coracohumeral ligament and superior glenohumeral ligament and subscapularis tendon. So this, if we mix both these two things, and this tendon pops out from this bicipital groove, that is a type 3. So if you see Bennett's type 3 here, I can, yeah, there is subscapularis partial thickness tear. We can see the lateral coracohumeral ligament complex is intact, but medial band of coracohumeral ligament and superior glenohumeral ligament complex is torn. Here you can see the tear. This long head of biceps tendon is popping out and subluxating from the bicipital groove. This is a type 3 Bennett's tear. One more thing is a type 4 where this the tear is there in this lateral band of coracohumeral ligament. Till now, 1, 2, 3, there is no tear in the lateral band of coracohumeral ligament. But in type 4, we have tear in the lateral band of coracohumeral ligament. In type 5, what happens is tear of everything. There is tear in lateral band, medial band, and also subscapularis. I'm going to show you the type 4 Bennett's. It is better seen on axial images. So I'm showing it in axial images. You can see our subscapularis tendon is intact, only partially torn, not completely torn. The long head of biceps tendon, if you see, this is the long head of biceps tendon, medially subluxated, and there is tear in the lateral fibers, lateral band of coracohumeral ligament, not the medial complex. It is in the lateral band. So this is a type 4 biceps instability. As we seen in Bennett's type 5, there will be tear of everything and the long head of biceps tendon will come out. So there is tear of medial, lateral band, and subscapularis, and the long head biceps tendon is completely in the medial aspect of the bone, humerus. So this is the type 5 Bennett's classification of subluxation. Then this is about biceps tendon subluxation. The next part is adhesive capsulitis. What is adhesive capsulitis? What exactly we see? I'm just putting this for your reading. But usual MRI findings in adhesive capsulitis is thickening of coracohumeral ligament, increased signal intensity of inferior axillary pouch and thickening of the axillary pouch. There is inflammation and soft tissue thickening in the rotator interval. There is thickening of the joint capsule. If you give contrast, then contrast enhancement of the rotator interval and also inferior glenohumeral ligament. Along with that, if I'm doing an arthrogram, the distensibility of the joint capsule is limited. So these are all the findings we see on an adhesive capsulitis or frozen shoulder. I want to show a case of periarthritis or adhesive capsulitis or frozen shoulder, which has multiple names. So usually I prefer seeing it in a coronal plane where I'm seeing this is the axillary pouch or axillary recess, inferior glenohumeral ligament, which is thickened. We can see it is thickened. This is all almost around 8.5 mm and shows increased signal because of inflammation. If we see in a sagittal image, this is the rotator interval. This is a coracohumeral ligament. So thickened coracohumeral ligament. This is all thickened, almost 10 mm thickened. Coracohumeral ligament is thickened. So then that is one thing. And also there is soft tissue thickening and inflammation noted within the rotator interval. This is one more finding of the adhesive capsulitis. Usually we find thickened axillary pouch, then thickening and inflammation in the rotator interval. Okay. If you see, this is the joint capsule. You can see the joint capsule is also thickened and shows PDFS hyperintense signal. This is a case of frozen shoulder or adhesive capsulitis. Then one more case I am going to show is a subacromial impingement, which is pretty common nowadays. Either it can be a primary or secondary. Primary cause could be abnormality lying within the acromion process, whether it is an os acromion or type 3 acromion process or a bony spur in the acromion process indenting the distal supraspinatus tendon. Those are all things are primary. Secondary can be secondary to AC joint arthritis or any osteophytes at the formed secondary osteophytes in the acromion process or any arthritis. Secondary to trauma. And these are all the cases. So here we can see the tip of acromion process. This is the subacromion. This is the subacromion space, and this is the supraspinatus tendon. This acromion process is indenting the distal supraspinatus tendon and causing tendinosis, that is altered signal intensity, increased bulk of the tendon, obliteration of normal subacromion fat here. You can see it's clearly indenting the supraspinatus tendon. So why is it important to look at the subacromial impingement? Initially, subacromial impingement will have some limited movement and pain, then later presents with subacromial subdeltoid bursaritis, then tear of the supraspinatus tendon, which can be a partial thickness tear or a full thickness tear. So early identification and treatment of subacromial impingement is necessary. So this is about subacromial impingement. Then as we come, so then what are all the things we can miss on an MRI? So there's an article from AJR, American Journal of Radiology, says that MRI can detect most of the pathologies, but there are some limitations. Right? it can miss the glenoid articular cartilage defects like SONC or osteochondral lesions. Those things cannot be accurately picked up. Then partial thickness rotatory cuff tears sometimes can be missed. Then partial thickness tear of long head of biceps tendon can also be missed. Superior labral anteroposterior tear, slab 3 and slab 4 tears can be missed on MRI. And adhesive capsulitis sometimes in early stages can be missed on MRI. Biceps pulley injuries is another case where we can miss the thing on the MRI. These are all different things which we may miss on an MRI. So this is most of my presentation. I touched most of the topics, and I really didn't go so deeply. If you request to go in depth, I can go into that in the next session. So what exactly we are planning is like a monthly session on MSK, showing just like we did a shoulder right now. Next month I would like to do an ankle if you are interested. Then the next month I will do a wrist. So every month in the first Thursday we would like to do one MSK session. And what next is like after 2 weeks from now, in somewhere in the third Thursday or Wednesday, based on the discussion. So we can put a case discussion session where we discuss the shoulder right now. If you people can send across me cases, 10 shoulders we can discuss on that day. So one evening we can put 1 hour and discuss all these 10 different shoulder cases. If you can send me a 1 week prior. Those things you can send me on a Gmail. So for that, if you can join this group where we are orthopedicians and radiologists can join this group, if you scan this QR code, you will be joining into the WhatsApp group. And we will also be sharing the joining link on the Zoom chat box. So by that also you can join. We can discuss and put various education sessions on musculoskeletal. One teaching session, one case reading session, 2. So every month we can have one case discussion session and one teaching session. So this is what is my session. Thank you.